I'm very excited to reintroduce Augustine for a session on modern postpartum hemorrhage practices. Most of you do know her, and we already introduced her yesterday, but for those of us who are joining today, Augustine is an internationally recognized midwifery educator. She's an experienced birth business executive, and she's a midwife of 25 plus years with a focus on the underserved, marginalized, and the under-resourced. She has a very wide experience in different birth settings, birth centers, home births in rural, urban, and suburban environments, hospitals of different settings. And in addition to her midwifery training and experience, Augustine also has a public health degree from Bastyr University of USA, where she majored in maternal and child health systems. Really, she has been a very strong voice in the global midwifery field, and she really wants to deconstruct the culture of fear and misinformation that surrounds birth. And as I mentioned today, she will be talking about modern postpartum hemorrhage practices. So please take it away, Augustine.
Thank you, Chetna. It's such a pleasure to be introduced by you and to be hosting this conference with you. And welcome to everyone who's joined. I'm really excited to share some clinical content with you. Much of this conference is about philosophy and care models. And today, especially with my content, we're going to get really into the nitty-gritty. We're going to get to the actual clinical practice. So I'd like to just, before we jump into the content, I'd just like to tune in with everyone and say, we have a very wide audience in this conference, and of course, watching the videos after the conference, folks who are parents themselves, just thinking about getting into birth work, all the way up to obstetricians who do cesareans daily. And so that's a huge variety of experience and concepts and focuses. And so today's content is very much focused for the provider. That doesn't mean that non-clinicians will not get anything out of it. I'm sure that you will take away a lot. But just like our last presenter last night, Dr. Parmila, who was talking about neonatal resuscitation. Today's content is also going to be pretty content heavy and pretty clinical, and has some concepts that folks who are new to birth work might not understand. So I love to answer questions. If something comes up that you don't understand, please drop it in the chat, and we will have a full question and answer session afterwards. And if it feels really overwhelming, I also kind of want to hear that too, because that's part of the learning process. So as Chetna said, I've been doing this for a while. I do a lot of things, and one of the things that I love to do is being the principal at Midwifery Wisdom Collective. You can follow us at midwiferywisdom.com in the US and .in in India. And we are just beginning our consulting services here. So really exciting to be a support for folks who are adding midwifery services. I wanted to start with a few guiding principles and core beliefs, because we don't always know where people are coming from. So I'm going to try to make it really clear. Number one, birth works. Fundamentally, birth is a normal physiologic process that humans were actually designed to do, and it works really well. All we have to do is look at the population, and then we know birth works. We know that birth happens best inside of a person who feels supported and not pressured. And when support people are qualified to manage emergencies, but also skilled enough to risk assess that when normal needs no intervention, that balance we've been talking about. Birth in Indian hospitals is mostly violent and dehumanizing. This is a core understanding I have since being here for 3.5 years and discussing with many providers and parents alike. Regardless of the mode of birth, women in India mostly leave their experience traumatized and healing from a cut of some sort. 2 simple changes could revolutionize women's experiences in this country. Number 1 is evidence-based time expectations for labor. This is beyond the scope of this presentation, but just very briefly, the normal length of labor for a preemie is 27 hours. The 6 hours that are given for folks on Pitocin is ludicrous. We have to change that. It's not evidence-based, it's not real. The other thing that could radically change women's experience is true informed decision-making processes, so that when we have a choice point, we bring it to the client, and we have the option for informed consent right next to the option for informed refusal. That is a true change that would solve so many issues. I also really believe that midwives are the experts in normal and should be the primary care providers for low risk normal births and labors of newborns. And I believe that highly trained surgeons like obstetricians are a vital part of the care team, but they have no place taking care of normal births. They should be utilized to manage the high risk and the complicated cases. So those are some of my guiding principles and core beliefs. And I know several OBGYNs who provide lovely, compassionate care and do normal births. But really, in that role, they're acting like a midwife. They're not acting like a surgeon. And I think we really have to make that distinction of which hat we're wearing at different births. So these are some of my core beliefs. So let's start with some hemorrhage. What is postpartum hemorrhage? It is excessive bleeding following the birth of a baby. About 8 to 50% of women in India have postpartum hemorrhages, and they are more likely during a cesarean birth. Hemorrhage most commonly occurs after the placenta is delivered. The average amount of blood loss after the birth of a single baby in a vaginal birth is about 500 milliliters and about 1,000 after a cesarean. Most postpartum hemorrhages occur right after delivery, but they can occur later as well. So let's take a look at a recent study. And I feel like this is really helpful because midwives take care of healthy, low-risk women. So why are they hemorrhaging? Well, the risk increases the more times we've had hemorrhage. So here you can look at with first-time pregnancies, about 5% of women hemorrhaged when they were low risk. They were assessed to be low risk. In second pregnancies with no history of hemorrhage, about 5% hemorrhage. And in third pregnancies with no history of hemorrhage, about 5% hemorrhage. So we can just see that even healthy, low risk, uncomplicated births, about 5% of the time we're going to experience a postpartum hemorrhage. However, once they have a history, the rate goes up substantially. And so this is why really good history taking is important, because while we can't always predict who will hemorrhage, we can know who has hemorrhaged in the past, which dramatically impacts our care. And so we'll talk about that a little later, but I just wanted to be clear. In India, the rate, especially in southern India, the rate of hemorrhage is much greater than other parts in the world. So these 5% might end up being 10 or even 15% in India. And we'll talk about active management soon. So I would love to just have you guys reflect. Have you ever hemorrhaged yourself? And you can use the little thumbs up button if you want to let us know, or turn on your camera. Has anyone ever hemorrhaged themselves? Has that ever happened in your own body? There's a few yeses here. I'm a yes. Sharda is a yes. Okay. Those of us who have hemorrhaged in our own body, it's important that we share our experience. It's a really extreme, intense experience. And we need to develop the sensitivity to meet those clients' needs even during emergencies. So we'll talk about that in a minute. The second question I have is, have you ever seen someone hemorrhage? Again, show of hands or comments. Yeah, most of us have if you're working in birth work. Okay. And have you ever managed a hemorrhage as a primary care provider? Yes, hopefully many of us who are actively primary have. And it's important to kind of understand the difference perspective that it takes to manage as opposed to witnessing that can cause some secondary trauma even, as opposed to it happening in our own bodies. So we're going to have an opportunity at the end of this session to kind of share some of those differences of opinions. But I just wanted to start that way because I think it's really important that, again, we bring that humanistic aspect into this place, into this birth, and that includes really understanding what people go through. So to diagnose and treat a hemorrhage, you must be able to remain calm and work quickly, utilize a skilled team, estimate blood loss, assess maternal vitals, administer drugs, start an IV, catheterize a bladder, suture tears, treat for shock, psychologically evaluate the whole situation, apply bimanual, and activate and communicate with the whole care team. I hope it's clear that it is impossible to do this alone. We have to dispose of the idea that there is a doctor or a midwife. And we have to really integrate this idea that we work in teams. So here is our hemorrhage skills management flower. And this is a way to kind of divide up all of those different skills that are needed to assess and treat a hemorrhage immediately. Certainly, there may be more extensive surgical skills that are needed for a small amount of people, but midwives are absolutely skilled when they work in a team to handle most hemorrhage emergencies. So kind of find your provider type there and go take a look at the skills that you might need to have as skilled upskill or really polished. Now, certainly midwives should have all of these skills. Student midwives should be learning all of these skills. Nurses probably would be able to do most of these skills, but it's about who does what in the moment. And that's a part of developing that team. Postpartum hemorrhage is defined as a loss of more than 1,000 cc's. And I would add a secondary definition, and that is, or blood loss significant enough to cause hemodynamic instability. So what does that mean? It means that they feel yuck. They are not stable. They feel dizzy, or they are feeling like they're graying out, or they're passing out, or they feel lightheaded, or they have tunnel vision or tunnel hearing. They are not comfortable in their body. That is another great way to define hemorrhage. And this way, we treat people according to symptoms as opposed to our sometimes erroneous estimation of the volume, right? So primary postpartum hemorrhage is loss in the first 24 hours. Secondary postpartum hemorrhage is loss after the first 24 hours, and both can be quite extreme. Why is postpartum hemorrhage a concern? Well, excessive and rapid blood loss can cause a severe drop in blood pressure. It can affect lactation postpartum. It can cause anemia and certainly iron deficiency. And the biggest thing is that it can lead to shock, hemolytic shock, and which is a positive feedback mechanism. In other words, if not treated appropriately, it will lead to death. And I think that this is a little bit of a scary reality, but it's a necessary reality when we're treating folks who have this risk. We want to look at the causes of maternal mortality. And here in India, the hemorrhage is still the biggest cause of death. And so, like, the timing couldn't be more perfect. The skills couldn't be more important for us to really all learn how we can save lives. When you look at all of the different evaluated causes of death globally, and we look at things that could be related to hemorrhage, we're looking at more than 75% of maternal deaths involve excessive bleeding. And so understanding how to prevent, predict, diagnose, and treat hemorrhage of all of its different varieties and presentations is literally life-saving. And anemia is another very important topic because anemia oftentimes leads to hemorrhage. Iron deficiency leads to anemia. And I happened to just do this presentation last night, and it's free. You can go and sign up if you haven't already. You have access to the videos until May or something like that. And I'm talking about iron deficiency and anemia in pregnancy. And so you can get even more details on that. So postpartum hemorrhage is a primary cause of obstetric bleeding and a leading cause of pregnancy-related complications and death. And every year, about 14 million women experience postpartum hemorrhage, resulting in 70,000 maternal deaths globally. The incidence of postpartum hemorrhage requiring blood transfusions more than doubled in the last 10-year period assessed, which represents a statistically significant difference. And uterine atony is the most common cause of postpartum hemorrhage, but there can also be genital tract trauma, like from vaginal or cervical lacerations, and definitely from episiotomy, which we've already heard from multiple speakers, is not evidence-based and should be discontinued immediately. India alone contributes to 15% of the global maternal deaths. And so again, a huge proportion of those are related to hemorrhage and blood loss, and this needs to be our primary focus. Some reasons why postpartum hemorrhage may occur: placental issues, an overdistended uterus, like with excessive amniotic fluid, multiple pregnancy when there's 2 babies and 2 placentas, gestational hypertension, preeclampsia, high blood pressure, a grand multip, someone having 5 or more babies has an increased risk of hemorrhage. Prolonged labor, when they're in labor more than 28 hours, they can have an increased risk of hemorrhage. Infection, like a maternal fever in labor. Obesity, although I say this with a really strong asterisk. I know that this is repeatedly in the evidence, but I don't see it. I'm obviously just one person, but I think there are other reasons why People have obesity, and so those are probably more the cause than just the excess body weight. Medications to induce labor, like an oxytocin drip, and medications to stop labor, like in preterm labor, can also increase the risk. And then certainly vacuum assisted and general anesthesia, and obviously episiotomy, like we mentioned. The second column is here. Postpartum hemorrhage may also be due to other factors, including that routine episiotomy, second degree tears, tear in the uterine blood vessels or cervix, bleeding in concealed tissue like a hematoma, blood clotting disorders, although very rare. We spend a lot of time talking about it, but it's incredibly rare. And then, of course, the placental issues. So, what causes postpartum hemorrhage? Once the baby is delivered, the uterus normally contracts and it tightens around the empty space, expels the placenta. And then once the placenta is delivered, those bleeding vessels that used to feed the placenta are contracted and the bleeding is cut off. But if the uterus does not contract strongly enough, called uterinatony, these blood vessels bleed freely, and that causes hemorrhage. Uterinatony, again, is the most common cause of postpartum hemorrhage. And if there's chunks of the placenta left inside, that can also cause bleeding. But it's important to note that the chunks of placenta have to actually impede the uterus from contracting. There are always minute amounts of placental tissue that is left in the uterus normally. We're talking about actual fist-size level chunks. And so examining the placenta after it's born is the way to assess for that. We know about the 4 T's. This comes from ALSO, which is Advanced Life Support and Obstetrics. It's an American family physician organization and training. And the 4 T's is a great mnemonic to help understand what could be causing it. Tone is the first T, and this is that uterine atony, the most common cause of bleeding. And about 70% of postpartum hemorrhages are due to uterine atony. So that should always be our first line defense. The second one is trauma, and this includes lacerations and very rarely uterine inversion. And about 20% of postpartum hemorrhage is due to that cause. Tissue, and this is where we have that retained placenta or retained pieces of the placenta. That could be about 10%. And then lastly is thrombin issues. And this is where we have blood clotting disorders and DIC. And this is really 1% of hemorrhages. So there's a lot of talk and stress and anxiety from providers around DIC and other blood clotting disorders. But we really need to put that on the back burner because it is truly 1% of the clients. The rest really are things that we can deal with. The vast majority of postpartum hemorrhage cases can be assessed and treated without entering the uterus. And in fact, entering the uterus after birth manually or with instruments causes pain, more trauma. It increases the risk of infection. It risks rupturing the uterus, and it's simply not evidence-based. So any of you providers who are here, please, please, please stop and ask your colleagues to stop the routine sweeping of the uterus postpartum. It really is a dangerous practice. So let's take a look at these 4 images. And I invite you to unmute yourself. And we're just going to do an experiment together. What do you see? What are similarities and what are differences? Anyone?
Hi, I'm Sophie. So the third
Hi,
image,
Sophie.
hi. The third image, the photo on the top, the third image along from left to right, you can see that trying to take the umbilical cord off around the baby's neck. There seems to be a little bit of stress. The people in the background, they're not really paying attention, except the woman to her left. Image 2 and image 4 are very similar. There's joy.
Okay.
Skin to skin is shining on image 1 and 2.
Yeah, I would say that all 4 images show a baby on their mother, right? All 4 images have providers participating.
Right.
All 4 images show mothers who are engaged and generally happy. Yeah.
I see 2 mothers are in upright position and 2 mothers are lying down. Is that anything?
Yeah, I see that too. Yeah.
Image 1 and 3 have direct skin-to-skin contact, whereas image 2 and 4 has some clothes around the baby with the skin-to-skin.
Yeah, I noticed that too. the first and the third images, the mothers are really active participants, whereas the other two, they're kind of observing. You guys see that too?
Yeah, I was there at the birth, image number 3, and you can see the mother unlooping nuchal cord
Mm-hmm.
by herself.
Yep.
Yeah.
Very active participant. In the two babies that have extra blankets on them, they're actually facing away from their mothers. Can you see that? So there's nothing right or wrong about any of these images. It's more understanding the subtlety of the things that we communicate to people at birth. So let's imagine that you're in one of these photos. Maybe you have a similar memory from your own birth from one of these. Or maybe you've been at a birth recently that's like this.
So I seen third slide, third picture wherein patient, mother is standing. So is this allowed? I just wonder sometimes if BP goes down for any reason, assuming any postpartum hemorrhage, is it allowed to stand immediately after delivery?
She actually gave birth standing. So
Okay.
Also, this is, the assessment that we do in the prenatal period, and also, continuously assess for normal BP and normal vitals for the mother, and normal heart tones for the baby throughout labor. So we know that at the point that she's giving birth, there is nothing unexpected that should happen.
Okay.
Now, if she were hemorrhaging after the birth, then we would definitely, move her quickly into a horizontal position and not be working with gravity. So that's a part of something that we do. But this mom didn't have any issues. We measured her postpartum bleeding, and it was about 250 ml.
Okay, thank you.
Thinking back to those 4 images, I just wanted to ask us to kind of group brainstorm. What beliefs would you come to know about yourself given those different scenarios? And one is not better than the other, but we do need to be aware of the subtle things that we are communicating as provider. So what would you imagine? I'll share the screen again and we can take a look. What would you imagine to be true? What would you imagine to be true if these were happening to you?
I think skin to skin contact helps in heat retention.
Skin to skin. If you had skin to skin, what would you believe about yourself or your baby or your birth?
That's your own.
That it's your own. Yeah.
Yes.
You can almost see like the women who are laying on their back, they're almost like, oh, is this mine? Can I touch yet? Mm-hmm. Right? Versus the other two that have taken full ownership of their baby already. And the way that we support births communicates this in multiple ways. We are a whole system made of energy, and we can't separate one from the other. Treating one always affects the other, and there is always a reason for a hemorrhage, whether you can identify it or not. Because there's always a reason, there's always a solution. However, working to stop a hemorrhage can be really scary and painful. So good communication is critical before, during, and after to prevent trauma and also to prevent lawsuits, honestly, because how you're treated in those vulnerable moments sets your memory for what it all was about. There can be psychological causes of hemorrhage, and I don't want to spend too much time on here, but I do want to point out this little piece here. Exhaustion can be a cause of hemorrhage. It is physically, emotionally, spiritually, and mentally exhausting. Fear can be a part of hemorrhage. You can be afraid of motherhood, the baby, someone in the room, or even just letting go. Grief can be a part of a hemorrhage, or letting go of a pregnancy that you loved, or of your pre-baby life, or your loss of independence. Anxiety can be a cause of hemorrhage. Sometimes crying for attention happens with blood. It can be overwhelmed in life, or it's a personally non-threatening way to communicate. Anger can be a reason for hemorrhage. You can be mad at all kinds of things, including the baby. Labor can be really hard, and we can have this misdirected anger. And then hemorrhage can be the cause, or can happen because of disembodiment. There can be lack of body awareness or connection, or there can be real disassociation because of a history of sexual abuse, or a history of hemorrhage, or a history of birth trauma, or sometimes simply focused on the joy, we forget to be embodied. So that bleeding happens. And this is a very advanced level of evaluating hemorrhage. And we're going to go into the very physical level as well. But I just wanted to ring the bell for the fact that there are multiple reasons why we're bleeding. With hemorrhage, we always need to be aware of a VBAC concern, although very uncommon. Uterine rupture can absolutely be life-threatening for the mother. And so if we have a vaginal birth after cesarean that has given birth and is excessively bleeding, it's really important to make sure that we do not have a rupture postpartum that is bleeding. We could also experience hemorrhage in pregnancy where there is concealed or obvious bleeding. And if you discover someone who's having a hemorrhage in their pregnancy, it's really important to prevent supine hypotensive syndrome by transporting that pregnant patient on their side. Like if after an accident, a car accident or something like that, they can't be transported flat on their back because the weight of the uterus can cut off oxygen and blood flow to the rest of their body. So we're going to focus mostly on postpartum hemorrhage. What are the symptoms? Uncontrolled bleeding, decreased blood pressure, increased heart rate, dizziness, ringing in the ears, that graying out or losing consciousness sensation, swelling or pain in the tissues if there is a hematoma. So quick note, most of the time, especially when a woman is under her own power and free of shoulda, woulda, coulda language, physiologic birth happens. They're not being told what to do or how to do it. Most of the time, a normal birth happens. So all of the discussions of the interventions that follow are for abnormal situations, and they're not to be used in normal birth. Again, we're focusing on the balance, the right care, the right provider for the right person at the right birth. So some basic treatments for postpartum hemorrhage. The aim of treatment for postpartum hemorrhage is to find and stop the cause of bleeding as quickly as possible. Treating postpartum hemorrhage may include correctly naming the psychological reason for her bleeding, helping the mom rise up and out of habit thinking and move into consciousness of the now. Your baby is born. It's time to arrive in your body, or we'll have those people leave that are obviously making you uncomfortable. That is a huge skill that midwives develop. Just simply putting the baby to breast can stop bleeding because the baby nuzzling at the breast, even before they've latched, can release more oxytocin, and oxytocin cramps the uterus. There used to be strong recommendation for manual massage of the uterus or fundal massage, but lots of evidence now points to that being actually a cause of bleeding. So it used to be a part, and still is in many places, a part of active management, where we do controlled cord traction, Pitocin or oxytocin injections, and fundal massage. But in studies that separated these three interventions, we found that controlled cord traction alone reduced the hemorrhage rate by 50%. We found that Pitocin alone reduced the risk of hemorrhage by 50%. Those two together reduced the risk of hemorrhage by 72%. But fundal massage increased the risk of hemorrhage by 15%. So my recommendation is to stop doing fundal massage. You can absolutely do a little fundal assessment. Is the fundus rising or falling or staying the same? You can lift right above the pubic bone and do a little ballottement to kind of wake the uterus up into its contracting state. But ultimately, if you find a boggy uterus, mashing on it does not make it contract. Medications make it contract. So we need to carry the appropriate medications to stimulate uterine contractions. We also have to be prepared to empty a bladder by catheterization. If they can pee, that would certainly help, but most of that area is sometimes a little bit numb, or there's lack of muscle control because a whole baby just passed through there. And so learning how to control their urethra immediately postpartum is not always feasible. We can remove placental pieces or clots that remain in the uterus. This is, again, a more advanced technique. I wouldn't do this first line, but if the uterus is full, it must be emptied in order to contract appropriately. And obviously examine for any areas that are injured and need repair. As we're losing blood, we want to replace lost fluids so that we can potentially prevent shock from developing, and we can give oxygen by mask. There are two very clear manual techniques involved in treating hemorrhage, and I want to really describe the difference. Hands should not enter the uterus. In the first left photo, you see someone doing bimanual compression. The hand is formed into a fist, and it is in the vagina, but it is not in the uterus. The fist goes into the anterior fornix, and the external hand wraps the uterus up and around that hard fist. This would compress those bleeding vessels where the placenta used to be attached if the uterus is not contracting on its own, this bimanual compression. And if you think about it, if you came across someone who's bleeding from their leg, you would put pressure on it because that is the smartest, most logical way to stop bleeding. So bimanual compression is absolutely a first line defense to stop bleeding urgently. Controlled cord traction is another way, a thing that we use to help with preventing hemorrhage. And this is the simplest, least invasive way to help empty the uterus. But the guarding part, guarding the uterus, is very important, and it's sometimes missed. So you can see the external hand is pushing down and up just above the pubic bone. And what this does is it makes sure that the bulk of the uterus can be felt. We're not holding it there, we're feeling it. So when the instrument is cramping the umbilical cord, where you can see at the very edge of the drawing, and the other hand is on that instrument, we can see that when we pull on that cord, we can feel the uterus come down or not with the external hand. If the uterus moves with your delivering hand, then the placenta has not separated yet. And if they move apart, then the placenta is separated. And that controlled cord traction, the control, is the important part. That external hand with pressure above is what controls you from accidentally prolapsing the uterus. So a very important skill to learn. We're going to talk about it a lot tomorrow at our Skills and Drills live workshop. There are some extreme measures like a Bakri balloon or a Foley catheter that we do put inside the uterus. Packing the uterus with sponges or sterile materials is not advisable. But if you have a transport, if we have to move someone from one hospital to another, or if there simply are not enough providers, so we need to actually have that pressure from the inside, but we don't have enough hands like to do bimanual, a Bakri balloon is a great option. Bleeding that has not stopped sometimes needs surgery. And of course, IV fluids will only work for a certain amount of time, and eventually we will need to replace lost blood with actual blood products to prevent hemorrhage. We need to get really good at blood loss estimation in order to do proper hemorrhage management. Doctors tend to underestimate, midwives tend to overestimate, and the accuracy is greatly affected by the location of bleeding. So if you're using a certain style of chucks pads, it makes sense to have your nurses or yourself measure a certain amount of blood, pour it into the chucks, find out how saturated it gets, lift it up, feel how heavy it is, and really get good at estimating location. In the toilet, on the chucks pad, in a birth tub, we have to get used to this. Direct action and treatment will really depend upon the woman's conditions and many other assessments. One last note about blood loss, and this is about H&H, or hemoglobin and hematocrit. A woman who starts pregnancy with a fairly low hemoglobin hematocrit are already compensated for blood loss. They're already compensated for that low level. So they will actually show hemodynamic instability much later than someone who starts pregnancy with quite a high level. So if they start pregnancy with like a 14 and 40, and again, this may not be realistic in a vegetarian population, but if they start with a high hemoglobin hematocrit, they might pass out at only a 500 cc blood loss. Versus starting pregnancy at a 10 and 28, they might walk around and get up to pee and get a glass of water after having dropped 1500 cc's. So it's just interesting to note that once someone is low, they are more compensated for blood loss, but that doesn't mean they should bleed. Again, we need to know what the location of bleeding is. We need to really measure our sanitary pads, our 4x4s, our chucks, and really get clear about what it is we're seeing with the instruments that we're using, with the devices that we're using, how much blood can it hold? And that will change our assessment and treatment of the woman. Identifying risk factors prenatally is really the best way. Has she hemorrhaged before? Does she have any issues that might increase the risk? Where is that placenta? Those are important skills. However, most cases of postpartum hemorrhage are not, there's no identifiable medical risk. So we need to be vigilant at all births. Active management of third stage of labor really does lower the risk of maternal blood loss and the risk of postpartum hemorrhage, especially in women who have risk factors. So I am a really big fan of active management in areas and with populations that could benefit from that. And certainly most of India has a very high hemorrhage rate, and active management can reduce that by a substantial amount. 72%, 75% of people avoid the hemorrhage if they are given Pitocin immediately and the cord is with active controlled cord traction, so we can have that delivery. But ultimately, our main job is to midwife her through her history and her trauma and her family situations and her fears, and help her choose the right people and the right location before she's even the birth in the first place, because we know what a big difference that makes. So let's talk about hemorrhagic shock. This is when we have lost so much blood that now it is threatening to our life. Classification of hemorrhagic shock is in relation to clinical criteria and the percentage of total blood volume lost. The total blood volume at term is approximately 100 milliliters per kilogram. So you can actually take your client's term weight and calculate their total blood volume. We know that blood loss greater than 40% is life-threatening. So we don't want to really have blood loss greater than 30%. So you can take that total blood volume, multiply it times 0.30, and you can get the acceptable amount of loss for that client, so that as you're doing risk assessment, as you're doing blood loss estimation postpartum, you can figure out who needs advanced help. So this is a really brief overview. The percentages relating to the liter amount is just an estimate, but just to get an idea, a class 1 hemorrhage is called compensated shock, and this is where they've lost less than 15% of their blood volume. If we can stop the hemorrhage at this point, all they need is physiologic support in the postpartum period. They need uterine tonic or medications to cramp the uterus. That might need a little oxygen. They might need to be able to kept warm, but they will recover without sequelae. They will be fine, because again, the blood volume adequately expanded in pregnancy represents about a liter. About 1,000 milliliters gives us that extra blood volume that supports a healthy pregnancy to term. So women are compensated. They're ready for blood loss of up to about 15%. When someone moves into stage or class 2 hemorrhage, they have lost 15 to 30% of their blood volume. This is when all the symptoms get really extreme. Their blood volume might drop. They might feel like they're graying out, blacking out. They might be dizzy. They might have a very fast heart rate, and they need all the things we have. They need IV fluids. They need that passive leg raise. We're going to talk about that in a minute. Oxygen, antihemorrhagic medications, and lots of efficient, quick action. Once we get into a class 3 hemorrhage, we have someone who needs blood products. They are in crisis. And of course, more than 40% in a class 4 hemorrhage oftentimes means that this person might die anyway, even if we get them blood after the 40%, because the damage to the capillaries and organ damage can be so severe that they die a week later. And unfortunately, we do see this in India. So critical, quick, efficient teamwork in the very early stages of hemorrhage really save lives. Preparation is key. You need to have O2 equipment nearby and set up, antihemorrhagic medications and equipment, skilled assistants, IV equipment, IM, and everyone has to know how to use these. We need to use calm communication. We need to have an open OR, OT, and OBGYNs available. And we need to have step-by-step protocols. So there's a primary assessment. How is this person? Airway, breathing, circulation. Should we move her to a higher level of care? The first line offering is definitely oxygen. If you have someone bleeding, someone should be putting oxygen on their face. How is their circulation? Are we having any kind of obvious signs of shock in their body? Remember, you can take the patient's pulse anywhere on their body that you are. If you're between their legs, you don't have to reach out to their arm. You can take their femoral pulse. Readiness is needed at every maternity unit. So have a hemorrhage cart with medication, supplies, and a checklist. Have an instruction card immediately available to remind of the clinical protocol in your hospital. Establish a response team. Know who to call when help is needed. Establish massive and emergency release transfusion protocols, and institute unit education on protocols and run unit-based drills. I can't encourage you enough. Run role plays, run skills drills, give your staff an emergency with no instructions, see what they do, run them through their paces. Practice really makes the difference. The step-by-step management of shock could kind of be divided up into a few different treatment plans. So what I'm calling treatment plan A is we begin oxygen supplementation, we gain IV access and administer IV fluids bolus, we give the anti-hemorrhagic medications, and we will start TXA. TXA is a new medication on the scene for hemorrhage, but it's saving lives. I would consider it more of an anti-death medication than an anti-hemorrhage medication because it helps to prevent those microclots that develop with DIC when we have excessive blood loss. Perform that passive leg raise. This is not Trendelenburg. This is literally someone holding their legs above their heart. We have about 300 milliliters of passive blood in our legs. And when we lift it up, we can transfuse their core body and help them feel better, as well as reduce the symptoms of shock. Keep them warm, touch them kindly. Reducing maternal deaths due to bleeding through scaling up of TXA for PPH treatment could have a really positive impact on the health equity, improve outcomes among disadvantaged women, especially in low or middle income countries. And this is a World Health Organization statement. So TXA is now standard of care, and we should be having it in all clinics. Treatment plan B is when we have already applied all the things in A, we need to reassess now. So once all the things have been added in A in as quick a time as possible, we're going to reassess the vitals. We're going to reassess the estimated blood loss or move to QBL, qualitative blood loss if possible. We're going to assess the uterine tone, assess the bladder size. And if it's all normal, we're going to keep following treatment plan A. But if it's abnormal, we're going to move to treatment plan C. And this is when we're going to draw and send for type and screen. Maybe you do this on admission. That'd be great. Hopefully you have some O-neg blood nearby. We're going to catheterize the bladder. We're going to sweep for any clots or placental pieces. We might apply bimanual or add a Bakri balloon, and we would administer that second dose of TXA, considering methogen if it's a low-lying placenta, and we would prepare to go to the OT if these measures didn't staunch the bleeding. And then lastly is when we move to plan D, and this is where we call in all the providers, we move to the OT, and we might use aortic compression as a temporary measure till we get them somewhere with higher level care. We might use a non-pneumatic anti-shock garment, again, as a temporary measure. But please, if you're going to institute those into your clinics, please make sure you know how the proper order to take the anti-shock garments off, because you can literally cause cardiac arrest if you take them off in the wrong order. Again, the use of uterine packing is really not recommended. That just absorbs lead and then we don't see the emergency. Uterine artery embolization is a conservative management measure. Postpartum hemorrhage is really not stopping. And then if bleeding really does not stop despite treatment, then surgical interventions might be applied. The priority is to stop the bleeding before the patient develops any coagulation problems or organ damage from underperfusion. Conservative approaches should always be tried first, rapidly moving to more invasive procedures if these don't work. So a review of the conservative practices, O2 supplementation. Anytime you suspect an issue related to shock, get out your oxygen. It is widely used in pre-hospital environments, and so it should definitely be used in hospital environments. Definitely have oxygen. IV fluids can be really aggressive. Run bolus to begin with for at least 10 minutes, where the normal saline or the lactated ringers or ringers lactate is running full open. We need about double or even triple the fluids for the amount of blood loss. Just a quick note here, we cannot give them fluids orally, and some kind of off-grid practices without skilled providers will do rectal fluids where they'll insert IV fluid into the rectum. These don't work. When the body is losing blood, the first thing that stops working is digestion because it's not needed to save your life. So you literally can't absorb those fluids. IV is the only safe way to treat them. We need to carry medications. Pitocin should be our first line defense. Oxytocin, it can be used intravenously or intramuscularly. Cytotec is another great offer, but it's not first line. Cytotec takes anywhere from 12 to 20 minutes to take effect, whereas Pitocin works in as little as 1 minute. So Pitocin or oxytocin definitely first. Methergin has a lot of side effects, and it's a really kind of a nasty medication, but it works really specifically on the entire uterine muscle, not just the fundal muscle. And so it's particularly helpful for low-lying placentas when we're trying to contract the lower uterine segment. Methergin is the only one of these meds that needs to be refrigerated. So that's another kind of barrier to use. The passive leg raise is simply what it sounds like, someone holding their legs above their heart. Keeping the person warm postpartum is really important. After childbirth, we lose the baby, the placenta, the fluid. We've lost a lot of heat. We have decreased that mother's core temperature by sometimes several degrees. They oftentimes will shake both from the hormones, the decrease in hormones, and also from the decrease in temperature. So having warm blankets and really taking that shake seriously because they're going to lose a lot more oxygen that way. So if they're also bleeding, adding warm blankets helps a lot. Don't underestimate the value of touching people kindly and talking to them nicely. Even during an emergency, you have time to explain what you're doing. And it really reduces their anxiety, which can help stop their bleeding. Because remember, this is not just a physical event, it's psychological as well. So overall, just reviewing again, the first step, empty the uterus. If the uterus has a placenta or clots in it, that must come out so that it can cramp. Also, if the bladder is full, that will hold the uterus up. So we have to consider catheterization. Contract the uterus is the next step with either uterine tonic medications, nipple stimulation, bimanual compression, whatever escalation you're in, the next step is to contract. We need to assess for tears and occlude any bleeding vessels. We need to replace lost fluid or blood products if we're at the hospital and we've lost more than 30%. And then we need to repeat steps 1 through 4 until stable and controlled or move to OT. After all of that intensity, and especially if they were expecting a really normal, calm physiologic birth, to be treated for a hemorrhage is very invasive. And so critical and crucial to her integration and moving beyond her birth experience is processing with her postpartum about what happened and what you did. Really try to wait until she asks about it. Talking at someone before they're ready can do more trauma. Don't try to process until she has at least slept for an hour or more. If no one slept yet, you're still in the trauma. There hasn't been reset. Don't wait until 6 weeks to process. It really needs to happen much sooner than then. Obviously, never use blame or shame or shoulda, woulda, coulda language. Always take responsibility for your actions and not acknowledging that you could have hurt her, but don't falsely reassure her. Try to answer every question she has, but if you really don't know, you say, I don't know, let's do some research. I'll need to find out about that. Really, the point is to gently help her understand the life-threatening experience that she has lived through and that everything that was painful or overwhelming was done to save her life. But we do that in a way that is as gentle as possible. So that is a lot, I know, and I'm really grateful to have skimmed the surface with you all. And I hope that I get a chance to go deeper with you when we're in person at some point. Hemorrhage is a really important topic. And I feel really passionately about helping providers be skilled during this emergency. I'd love to open up the floor for any questions and really see if there's any wrap up that we need to do. Hi, Dr. Geeta, do you have a question?
No, it's not a question. I just wanted to congratulate you on an elaborate aspect, which is usually a nightmare for every obstetrician. It was a very well thought and covering all the aspects of postpartum hemorrhage. And for me, the new thing was psychological causes for hemorrhage. So usually we know all 4 T's and we have the protocol, we have road drills, everything. But psychological aspects also cause postpartum hemorrhage is a new revelation for me. And we need to give importance to that also. That was a new thing I learned from this lecture. And of course, It was a very informative and useful session. Thank you so much.
Thanks for that. Dr. Gita, stay on with me for a second and I'll just do a brainstorming for everyone's benefit because I think this is a really interesting topic as well. That's why I'm kind of fascinated about it. So for everyone, use the chat if you can, and imagine that there are other times in our life when we bleed. When are those times? Can you think it through? What are the other times when we lose blood? When you're injured, right? You could bleed when you're injured. Every month with your menstrual period. Yep. You could bleed when you have a miscarriage. There could be internal bleeding, sure. Rectal bleeding, all kinds of places, right? So some of these bleedings, most of them, in fact, have emotions attached to them. So how do you feel when you bleed at other times? You could be sad. You could be super irritated that you're bleeding. You could be like, not pregnant. Woo, that was close. Yeah? Anyone ever had that one? You could be fearful, really terrified. What is happening to me? I don't know. There could even be joy, like, oh, thank God I got my period, right? So all of the emotions that we have are attached to bleeding. So it is also true in the postpartum. Emotions are attached to bleeding, right? And a good way to think about this is like, it's kind of crying, but down instead of out that way, right? So all the emotions of crying exist. We could be cried because we're happy, sad, all these things. We could do the same with bleeding. And so it's a new kind of understanding. But if we can look at this person like a whole person, it's not just her uterus bleeding, right? Her mind and her emotions and her family dynamic and her history. I mean, we cry when we're exhausted. We cry when we're overwhelmed. We cry when we're happy. We cry when we're sad. Bleeding can be the same way. So looking at that whole picture is really, really important. And treating them like a whole person makes a huge difference. Any other questions from today's presentation? I know, again, it's just scratching the surface. We're just at the very beginning of understanding this for some of you. But
Hi,
yeah.
Augustine. This is Asha. Can you hear me?
Augustine.
Yeah. Hi, Asha. Sure, go ahead.
Thanks for a great presentation. So if you were to kind of distill the most important points for very low income populations in India in terms of, ways to prevent, ways to minimize risk of hemorrhage in terms of what women can do themselves. So we've talked a lot about what providers can do, and we're very familiar with active management of third stage of labor and all of that. Of course, that doesn't always take place across the health systems, private or government in India. But we're trying to really kind of emphasize this need for empowering health education for lower income families, which is non-existent. So if you were to distill from all that you talked about in terms of, what are the most important points to share with populations, individuals like that, what would you say?
Yeah, it's such a great and important question, and it's so complicated by its intersectionality. If you were to ask me what is the thing that high resource people can do to prevent hemorrhage, that's a very simple answer, right? Eat better and hire midwives, right? There's ways that when you have a lot of resources, you can avoid many of the complication. But low resource folks, it's such a complication because they oftentimes don't have the education to understand the shift, or they don't have the resources to add in or change the lifestyle or the diet, or access different providers. And India really is just so challenging on many levels. If I were to distill it down to one thing, I would probably say anything that we can do to reduce fear is going to do the most benefit outside of what a provider can do. To decrease the hemorrhage rate. So having and demanding that people that they know and trust attend births with them as birth support, birth companions, and hopefully even birth providers. Choosing providers that they feel comfortable with, choosing locations they feel comfortable with. That can go a long way. Don't underestimate the power of fear in hemorrhage.
Great, thank you. That's really important. I don't want to take up time. I know there are other people who want this question, but just how does that really work? How is fear mediated?
Yeah, what is the biochemical reaction? Is kind of what you're asking.
Yeah, what is kind of exactly?
Yeah. Well, so in a very simple, simplistic kind of way, it has to do with basically two hormones. So oxytocin, is the hormone that causes contractions and love and bonding in all of those parts that are really prevalent in birth. And adrenaline, is sort of the hormone of fight or flight. There's two more, and that is freeze and fawn. And those 4F responses cause a very altered behavior. Additionally, biochemically, adrenaline is the antidote to oxytocin. So when we have fear in the body, the labor and the postpartum cannot function normally. Does that answer your question?
Yes. Thank you.
Thanks for that. Yeah. Shonda, tell us.
Yeah, hi, Augustine. I have this question, when you're mentioning about uterine atony as one of the causes of postpartum hemorrhage, you also mentioned uterine atony can happen because of episiotomy. Can you explain that?
Say that another way.
Uterine atony can happen because of episiotomy.
No, uterine atony doesn't happen because of episiotomy. Episiotomy causes an injury to blood vessels that are bleeding. So that's a separate cause. You remember the 4 T's? So uterine atony or tone is the first T, and then trauma is the second T, which is about that injury.
Yeah. Got it.
Yeah. And together, those make up, 90% of the reasons why we bleed. Dr. Geeta, did you have some other comment today?
I wanted to listen to some life experiences you had in your practice about postpartum hemorrhage.
Sure. Do you want to have anything more specific than
that? Nothing as of now. Oh.
Well, I would say we have to be ready for hemorrhage at every birth.
Yeah.
And I think a lot of midwives' energy should go into preventing hemorrhage. So low lights, calm voices, partners and support people present, no loud voices. This is kind of a bizarre concept, but I want to take you into how we reduce fear for the birthing person. Can even be a real elemental or almost DNA perspective. Like, for instance, the most recent predator of humans, right? Because we basically have no predators now. But if you can think back many generations, the most recent predator of humans was big cats, right? There are big cats here all over the world, and they sat above. They hunted from above in trees or in rocks, right? So humans have a natural DNA fear of things coming from above. Yeah, can you all follow so far? So in labor, when you're at your most vulnerable, I teach all my students to make a concerted effort to always sit below my clients. I'm sitting at level with them, or I'm actually sitting below them. And this will deactivate any actual subconscious DNA cellular fear that is encoded in us. And it's part of the reason we have so many dysfunctional labors in hospitals, because what's happening? Everyone's standing over them, right? So it's the way that we can change the literal environment of birth, changes the way birth unfolds. So one is prevention, which is the environment. 2 is compassionate, humanistic touch. That really changes everything. And then the 3rd is having a good team that's ready to act. We do nothing if there's nothing wrong. And sometimes we do everything if there's something really wrong. So a lot of challenge there, but I don't know. I think then Geeta, to answer your question fully, yes. I have never had to transport a woman to a higher level of care for hemorrhage, because if you know to act effectively right in the beginning, it almost never escalates, because shock is a positive feedback mechanism. There's always a reason for the hemorrhage. There's always a solution. And if we don't react immediately, it just gets worse. Now, at some point, if I practice long enough, I'm sure I'll encounter someone with a blood clotting disorder that is not solvable, right? Where we need extra care. But in 2,000 births, I I still haven't seen that. And so I just want to really remind everyone that this is a solvable skill. You can learn these skills. You can have technically excellent team members, like the different nurses and assistants that you may acquire. And you can give oxygen in an IV, and you can give the antihemorrhagic, empty the bladder, and contract the uterus, and the hemorrhage stops. And then we all go back to visiting with that baby and nursing and return to normal physiology. It doesn't always have to escalate. Escalation of hemorrhage treatment is usually because the early signs were missed.
I have another small comment to make. Because removing fear of childbirth is one aspect, whereas making them aware of such complications can happen is also another challenge in obstetrical practice, because many of the people and relatives don't know that such things can happen after childbirth. So in that case, it is a very unexpected situation for them. And to explain, sometimes whenever women die of PPH, it is a common scene to see people vandalizing the hospital doctor, because they are not aware of the complications that can happen after childbirth. So making them aware and removing the fear of childbirth, both together we have to do, and that is really a challenging situation. Maybe that is better dealt with childbirth classes.
Classes is a huge part, and then enough communication in the prenatal visit so that we are aware. And the bottom line is, like, you have a baby inside you now. That baby has to come out one way or the other. One way or the other, there is this risk and this risk and this risk. And we're going to try to minimize those risks, but your labor will unfold the way it does, and we will do our best. And I'm really getting people on board, like that you aren't over them in charge, that actually we're partners in this. We're working together. These are my skills. These are your experiences. We're going to communicate this way. And if and when you need care, we've built a trusting relationship so that you trust me to apply those interventions. And again, it's such a paradigm shift, because what's happening in India right now is so much overuse and over medicalization and over treatment that people have come to assume all of it's bad. And we do need to have that re-education to be like the timely, appropriate use of intervention in the appropriate situations. And communication is key. Yeah.
It's rather fear of PPH in obstetricians rather than patients.
We do need to tackle that as well. And I would love to teach more workshops with more OBs like yourself, Dr. Gita, because it is so important that the provider can enter the birth space without all the baggage from the last 500 births, the last 5 births. We have to be present in this moment so we can risk assess. Thank you, Dr. Gita. And I'm happy to answer any other questions. Well, going back to the first questions I asked you, if you have managed a hemorrhage before, have you been scared? Well, you're scared of what was going to happen? Did you know what to do? Were you overwhelmed? Anyone? And I think if people answer honestly, you would find that even though we manage hemorrhages successfully, there's always a little fear in the background. There's always a little anxiety. And I think that's important to acknowledge, and I think it's normal. If we're really honest with ourselves, attending births is a life and death experience, truly. A lot of life comes in, right? A lot of magical life, but we cannot prevent all deaths. And I think when we come up against emergencies, we have to really acknowledge that truth of how much weight we walk with on our shoulders when we're dealing with these situations. And so I think really shifting from a blame and shame kind of perspective, and like you should have been able to, or, really shifting to a compassionate place to say, this is scary. I don't have all the answers, and this can be challenging. I need my team together. I need my client to be fully informed. I need my medications. I need to have step-by-step protocols. But I don't need to walk in fear because I have all these things in place. Like Dr. Gita is saying, a lot of over medication, overreaction is fear mediated. And also sometimes it's even a reaction to the legal system, right? If you can justify, I did everything, then you might be more likely to escape persecution. But actually, those interventions can sometimes cause the very complications we're trying to prevent. So thoughtful, compassionate, kind, patient movements is what's required. Yeah. And skilled hands, come to the trainings, practice run drills with your teams, know how to affect change, know how to act appropriately. Alrighty. Yes, Sophie, gentle, calm communication is so important. You are right. Well, thank you everyone for spending time with me on this important topic. We are going to have some hemorrhage conversation tomorrow in our hands-on skills training. And I'm really grateful to be with you all.
I have I have something that I want to share if you have a minute.
Sure.
So during my delivery, I have two children. One is 14-year-old and one is 10-year-old. Way back when I had my first child, so both the times I had same complication. Both were normal vaginal deliveries, but then in the first time also I had this atonic bladder, and nobody could identify the reason for my PPH. And literally, me and my husband, both of us are doctors, and we used to work with Manipal Hospital that time. I mean, he was working, I was on break. But then we were the ones who diagnosed that maybe bladder is not empty yet, and literally, pushed the, catheter. And then once bladder got evacuated, that's when the bleeding stopped. So really, I get scared even till date that if I was not a doctor, me and my husband, what would have happened to me? Because doctors were not able to trace in what's the reason for PPH. They rushed me back into the labor room, and they tried to reopen stitches, and episiotomy was also done. It was such a painful experience, and I when you're saying so, all these things, I was just recollecting those moments of mine when those things happened. Anything can be reason for PPH.
I'm so sorry. That is really traumatic. Yes, the first step to solving a hemorrhage is empty. What do we empty? The uterus and the bladder. Those go together. Then contract. The uterus has to contract, right? So unfortunately, your docs missed a step, and I'm so sorry for you. That
like you mentioned, the initial step was missed, a very crucial one.
Yep. I'm so sorry that you had to live through that. Thank you for being here with us today and for sharing your story. It's really meaningful for all of us providers to remember how impactful our actions and our words are on our clients. Thank you. Well, we are going to take about a 5-minute break to get reset before our next session. And I encourage everyone to get something to drink and get comfy. And we'll see you all in just a minute.